录音结束了。Hello, Dr. Molina.
Hello. Can you hear me?
Yes.
Perfect.
So we need to test the slides and see if everything goes well.
Perfect. Can I put my slides?
Yes.
Perfect. And how can I put them? Or
Please wait a second and we will stop the sharing of the slides and you can start your slide sharing.
perfect.
Yes, it works. So you can share your screen. Let's check whether the slides goes well.
Okay. How can I put my screen, my screen?
You can click the button, like sharing the screen. Can you see that?
I don't see that button. Share the screen.
Probably the green button under the screen.
Oh, okay, perfect.
Okay, Dr. Molina.
Mm-hmm. 1 second. Okay.
If you cannot share,
Are you seeing? Are you seeing this?
If you cannot share the screen, I can share it on your behalf. Since you have sent the slides to the editorial office, okay?
Okay, yes, I only made a little change, but
Yeah.
no problem. Yes,
Okay.
will be easier.
Yeah, thank you so much. So Dr. Cato, can you hear my voice?
Yes, I can hear your voice. Yeah.
So can you share your screen and let's check the whether the slides
Yes.
goes well.
I have just sent you slides.
Yeah.
Have you got this?
Oh, we have got
No?
the slides, but it's a little bit huge and
Huge. Yeah, okay. So okay. So please, Dr. Morena, please
Yeah,
stop sharing.
stop the sharing. Yeah.
Dr. Molina? Oh. Can you make your... Oh, okay.
So,
So, Mary?
Yeah.
Hello? Did you get all slides for the presentation?
We only got we only got 4 slides at present.
Only 4. Yeah. So other than that, the presenter should share their screen and that kind of things.
Yes.
Okay.
I'm sorry, I can't find my slides.
Okay, we can wait a second and
Yes, please.
let's check another ones.
Yeah.
Dr. Shink.
Yes, hello.
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 Can you share the screen?
Okay, wait a second. How
Yes, we
how
can.
is this?
Yeah, it
Can
goes
see it,
well. We
yeah.
can see it clearly. It's okay. Thank you so much.
Okay.
Can I try again?
Yeah, yeah, of course.
Um, um, I'm sorry. I can't find it. Okay, go ahead. What other one?
Yeah, Dr. Ishan, can you share the screen?
Hello, can you hear?
Yeah, yes, I
Yeah.
can hear your voice.
Sharing. It's okay. Can you see?
Yes, I can see your I can see your screen.
Right, show.
Good.
Good. Thank you. Thank you very much.
Thank you. Thank you.
for your
Mm.
Hello, Dr. Kidachi. Can you hear my voice?
Yes, I can hear you. How
Yeah.
about my voice?
I can hear your voice clearly.
Hi.
Hello.
So for now, I should share my slide.
Yes. We need to check whether it goes well.
So how it's going.
Yes, I can see the slides. Yeah, it works well. Thank you so much.
Hi, thank you.
那两人没来，是不是？Dr. Kato?
Yeah.
Yeah, I just saw your slides.
Oh,
Yeah, it's good. It's good.
can you see my slides?
I saw your slides
yeah,
just
yeah,
now,
yeah.
and maybe you stop sharing.
Yeah.
Yeah, it looks good.
Looks good. Okay.
Thank you.
Thank you.
And up to now, we still have 2 speakers not entering the Zoom, so we need to wait about 1 minute. Okay.
Okay.
So we are going to start or wait some.
Okay, we can start now, and if the other speakers can't enter the Zoom, and we will follow the order of the other speakers. Okay.
Okay, so we are going to start this session. Thank you all for your participation. Today we have special issue related mini invasive surgery journal webinar. The topic is current and future treatment of hepatocellular carcinoma, HCC. And today invited authors for the special topic. 7 speakers are going to present their papers, hot papers. So we are going to get started. So please, first speaker, Professor Yutaro Kato from Fujita Health University, same as me, but different hospital. He's a famous professor in Japan as a robotic liver surgeon. So please start, Professor Kato.
Yes. Thank you, Professor Morise, for a kind introduction. So I'm going to start my presentation. I will share the slides. Can you see the slides?
Yes.
Okay. So I first of all, I'm very sorry that I have to change my title of my slides per paper because robotic liver resection for liver tumors is too much for me. So I changed the title, robotic parenchymal sparing anatomic liver resection for hepatocellular carcinoma. Introduction, minimally invasive liver resection has been accepted as a reliable treatment modality for hepatocellular carcinoma. And to balance hepatic functional reserve and cancer curability, a parenchymal sparing anatomic resection is recommended for HCC. However, these procedures are technically demanding in minimally invasive as well as open approach. A robotic liver resection is a new MI hepatectomy platform, which is expected to lower the hurdle of demanding types of resection, such as parenchymal sparing anatomic resection. However, the feasibility and the safety of robotic approach have not yet been established. In this study, we present our surgical techniques of robotic parenchymal sparing and anatomic resection and compare perioperative outcomes between laparoscopic and robotic parenchymal sparing anatomic resection for HCC using a propensity score matched analysis. As of May 2022, we have done a total of 128 cases of robotic resection. And among these cases, HCC accounted for 81 cases. And in this study, we focused on the anterior sectionectomy, posterior sectionectomy, medial sectionectomy, and sub or segmentectomy. So surgical techniques, a basic concept of liver resection for HCC. We have to both consider cancer curability and hepatic function reserve. The cancer curability is important because HCC disseminated transport vein, and functional hepatic reserve is important because the patient has underlying liver disease. So parenchymal sparing anatomic resection is recommended for HCC to balance these two factors. Lennox capsule is a proper membrane covering the hepatic parenchyma, and this is an important structure, anatomical structure for anatomic resection, for, particularly using extrahepatic glicerine approach. And this anatomic structure is revisited by Professor Sugioka from Fujita University. And we we standardized anatomic resection based on Lennox capsule theory. And this is the highlight plate, and this is cystic plate. These can be detached from the liver parenchyma, detached from the Lennox capsule of the liver parenchyma. So we can enter these spaces extrahepatically to isolate these Gleasonian pedicles extrahepatically. This is, sorry, this is a Gates theory, and we can access or isolate the Gleasonian pedicle from these 6 gates, we think, very easily. So we have to keep on dissection on this plane and gates to safely isolate the Gleasonian pedicle extrahepatically. This is our method of anatomic resection based on extrahepatic Gleasonian approach and hepatic vein route at first parenchymal dissection. Left hepatectomy, central bisectionectomy, segmentectomy 8, and caudate lobectomy. This is an example of anatomic segmentectomy 8. This is a laparoscopic case. First, we approach the anterior Gleasonian pedicle. This is the anterior pedicle. We isolate it first. And then we isolate the Gleasonian pedicle of the segment 5. And by the subtraction method, we isolate the segment 8 pedicle and clamp this pedicle. And you can see the demarcation and isolated ischemic segment 8. This is the isolated segment 8. And then we approach the root of the middle hepatic vein, and parenchymal dissection is started from this place, and dissection is continued from the left upper side to the right caudal side. It's the right hepatic vein. Sorry. And this is the Grayson pedicle of the segment 8, which was already exposed at the hilum. Sorry. This is the robotic anatomic segmentectomy 8. Very similar method as the laparoscopic approach. But the robotic ergonomics is very useful to isolate segmental or sectional Graysonian pedicle extrahepatically. And we isolate segment 8 Graysonian pedicle and clamp this. As you can see, this is a firefly mode. And you can see, identify the ischemic segment 8. And in the same way as the laparoscopic approach, we approach the root of the middle hepatic vein. And parenchymal dissection is going from the left side to the right side. Such tying is very easy by robotic techniques. This is a final view. Okay, I'll skip the next one. And I analyzed the perioperative outcomes after a sectionectomy and segmentectomy cases. This is, we have done 78 laparoscopic PSAR and 33 robotic PSAR. And the background quite different. And in laparoscopic cases, and cirrhosis are more, and in robotic cases, there were more previous hepatectomy cases. And tumor size are bigger in laparoscopic, and in robotic cases, tumors are more in number. And this is non-matched perioperative outcomes. These are comparable between the two groups. And we have done propensity score match analysis on perioperative outcomes, 25 laparoscopic and 25 robotic cases. And this analysis showed there were no difference between laparoscopic and robotic approaches to such type of anatomic resections. So in conclusion, robotic approach to parenchymal sparing anatomic resection for HCC was suggested to be technically feasible and safe, with comparable perioperative outcomes with those of laparoscopic anatomic resections. And with refinement of robotic techniques, further larger studies are needed to identify the potential merits of the robotic approach to parenchymal sparing anatomic resection for HCC. Thank you for your kind attention.
Thank you very much. Thank you, Professor Sato.
Thank you.
So now this paper is open for discussion. We have 5 minutes. Is that right?
Yes.
So please feel free to ask a question or say some comments from presenters. There's no comments. I think your procedure, like extrahepatic Grisoni approach to parenchymal preserving small anatomical resection, in that kind of procedure, robotic is very useful, I think. But there's no short-term outcome difference between lab and robotic. That is what come from that kind of no difference between those two cases.
I'm not sure, but probably robotic approach is now on the way of development. So I think if we refine our techniques of robotic resections, we think that a little bit merits can be found.
Yeah.
Superiority. I think in my experience, there is a superiority, potential superiority of robotic approach, in that they have very little rate of bile leak.
Yeah, that's right.
So in this series, there are no bile leak in robotic approach as compared to the laparoscopic approach, where probably 3 or 4%. So if we perform larger studies, we can find significant difference between the two approaches.
Yeah,
in this time.
I also believe that because like your approach going through to the peripheral part of Grisonian pedicle, in that case, in lab approach, we can easily get some kind of small injury on the biliary tree.
Yeah.
That's different from robotics, I believe.
Yeah.
How about the major hepatectomy, for example, right hepatectomy or left hepatectomy? In that case, there's some kind of advantage on robotic.
I think isolation of in isolation of the Grisonian pedicle, probably a robotic approach is superior, I think. But a large dissection of large plane is not so good for robotic approach, because we are still short of appropriate parenchymal dissection instruments in robotics now. We have to develop.
That's right. It will be improving, and you will get something you can use.
Something new.
Yeah, that's right. So other than that, there's no question or comments for his robotic presentation. Okay. So thank you very much. Thank you.
Thank you,
Professor Kato. Oh,
thank you very much.
Some comments here, and oh yeah. So thank you very much.
Thank you very much.
Thank you very much. So I'm looking forward to seeing your paper in this generation. Yeah. Thank you very much.
Thank you.
So let's get on to the next speaker, Dr. Jun Ishii from Toho University. Toho University is also in Japan, and very long tradition for lap liver resection. Actually, Professor Kaneko is one of the pioneer of lap liver resection in Japan. He's the world first reporter of lap left lateral sectionectomy. So please go ahead to your presentation, Dr. Ishii, please.
Thank you very much, Professor Morse, for giving me the opportunity to present our data in this webinar. We would like to present about technical aspect on laparoscopic liver dissection on the Spiegel law. Caudate law of the liver can be divided in 3 portions: Spiegel law, paracaval portion, and caudate process portion. It is located between the higher plate and the inferior vena cava, IVC. Liver resection of caudate law has been considered as technically difficult for both open surgery and laparoscopic surgery because of its deep anatomical location and its proximity to great vessels. However, Spiegel law is located almost to the left side of the IVC, and surgical field of Spiegel law could be ensured for laparoscopic caudal view and magnified visual effects. So laparoscopic surgery may be suitable for liver resection of Spiegel law. We describe surgical technique and our experience in this paper. First, we could like to introduce our procedure. This slide shows our patient position and port placement. Patients were placed in the spine position, and usually the surgeon was standing on the patient's right side. The first assistant and the camera assistant on the patient's left side. 5 port sides and finger maneuver was used. New peritoneum was established at 8 to 10 millimeters of mercury. In this surgical procedure, we describe our basic elements in the laparoscopic liver section of Spiegel law. The left lateral section was lifted upward with a subxiphoid port. The left segmentum was excited to expose the Spiegel law. Intraoperative laparoscopic ultrasonography was performed to confirm the size of lesions and its relationship to the main hepatic structures. Finger maneuver was prepared to control the hepatic inflow. The hepatoduodenal ligament was retracted to the right. This slide shows the mobilization of Spiegel law. The hepatocaval ligament was incised to free the left lateral border, and the left vena cava ligament was divided. The Spiegel law was lifted to identify the short hepatic veins. These were clipped and dissected carefully. The appropriate surgical field was gained by laparoscopic caudal view. If total Spiegel law section was performed, one or several Grisonian branches of the Spiegel law were exposed from the higher plate. It was clipped and dissected. The hepatic parenchymal transection was performed with a clamp crushing technique or dissecting using laparoscopic capitulum ultrasonic surgical aspirator, CUSAR. Intermittent Pringle maneuver with a 15 minutes ischemic interval was applied. The small vessels and bile ducts were controlled with end clips or using energy devices one by one. The specimen was always in a laparoscopic bag and extracted through the umbilical incision. Then the resection area was checked for bleeding and biliary leakage. Finally, one suction drain was placed. Next, I will show you our cases. Case 1. This case was laparoscopic total Spiegel law resection. SCC 1 centimeter in diameter was located in Spiegel law. The Grisonian branch was dissected, and the hepatic parenchymal transection started from the caudal to the cranial direction along the IVC with a clamp crushing using bipolar sealing device. It's almost straight line. Next case was laparoscopic partial hepatectomy of the Spiegel lobe, preserving an accessory left hepatic artery. Liver metastases from rectal cancer were diagnosed. The region 5 millimeters in diameter located in cranial part of the Spiegel lobe. In this case, only the cranial part of the Spiegel lobe was mobilized from the IVC, and the hepatic parenchyma was dissected, acquiring adequate surgical margin without injury to the confluence of left hepatic vein safely. This patient was a technically challenging case. It is not only Spiegel lobe resection. Intrahepatic cholangiocarcinoma 3 centimeters in diameter was located in segment 4, abutting middle and left hepatic vein and extracted to the Spiegel lobe. Laparoscopic extended left hem hepatectomy plus total Spiegel lobe resection was performed. This figure shows the stump of the middle hand, the hepatic vein trunk, left hepatic duct, artery, and portal vein. There were no postoperative complications in these cases. In discussion, laparoscopic surgery approach to the caudate lobe has specific technical challenges because of its proximity to the IVC, major hepatic veins, and the hepatic hilum. We found several case series and cohort studies of laparoscopic surgery for the caudate lobe. This slide shows multi-center cohort studies. They reported that laparoscopic liver resection of the caudate lobe was feasible and safe. Or laparoscopic resection has obvious advantages compared with open resection. In these studies, many Spiegel lobe cases were included. We found that majority of the cases for these caudate lobe resection were Spiegel lobe resection and Spiegel lobe related resection. So, in conclusion, laparoscopic resection of Spiegel lobe is feasible and expected to be widely accepted. Thank you for your attention.
Thank you very much. Thank you for your very beautiful presentation. So this paper is now open for discussion. How about some speakers, panelists, has some comments or questions?
Well, I will make a question if I can.
Please.
Congratulations for this presentation. I only wanted to ask, if you only want to resect the Spiegel lobe, it won't be easier to go by the left side of the Spiegel lobe and not be in the right side of the patient?
Thank you very much for your good question. I couldn't. Are you asking about right border of Spiegel law?
Yes, if you only want to resect the Spiegel law, it's easier to be in between the legs of the patient and go more by the left side approach of the Spiegel law than going from the right side.
Oh, we presentation is only Spiegel law resection. Almost left approach and caudal approach. Right side, for example, paracable portion resection was difficult. It's controversial. So
Yeah, I agree to Dr. Ishii because for Spiegel lobe resection, left side approach is best because we got a very good view and operative field from left side approach. So instead of the paracable portion resection or that kind of things, we usually don't use that kind of a light side or caudal approach for Spiegel lobe. For the paracable portion, we usually do it from caudal approach and also right-hand side approach. But for Spiegel lobe, this, I believe, Dr. Ishii's presentation approach is best for that.
Thank
very
you.
much.
thank you.
Hello,
Thank you very
everyone.
much.
Oh, thank you, Professor Otsuka. Can
Hello.
you
Yes.
some comments for?
Yes. I'm a co-author of Dr. Ishii, and we usually place surgeon's position on the right side of the patient because we usually use our right hand for the energy device. So we usually stand the right side of the patient. Okay. Thank you.
So I have one more question. Before that, Dr. Kaizu from Kitasato University have one comment. Do you always Grissom resection first? His question. How about that?
Can you give
Oh,
one question?
please.
Hi, my name is Takashi Kaizu from Kitasato Medical University. And thank you for your presentation. Very nice view, especially the last case. That's very fantastic view, last view. And my question is, do you always reject the Grissom first? Because for us, it's a little bit difficult to recognize a very tiny Grissom, Spiegel Grissom. So usually we will reject the transaction first, and after that, during the rejection, we can recognize the Grissonian pedicle, tiny Grissonian pedicle for the Spiegel lobe, and gradually reject transaction rejection first, and next Grissom rejection and transaction and Grissom like that. So do you reject always the Grissom rejection first, or can you understand my question?
Yes.
Sorry, I can't. Difficult to.
Yeah, that question is partially related to the Dr. Morine's question and also Professor Otsuka's comment. For my experience, I usually stand left side of the patient in that case because I'm doing left side approach and dissection of IVC and the hepatic vein first. And after that, we are going to do the liver transaction. In that case, first left side standing and do the dissection of IVC and hepatic vein. And after that, from caudal side, sometimes move to the right side of the patient. And from caudal side, we are going to dissect the liver parenchyma. So that's related to the standing of the surgeon and approach from where do you approach first. That kind of we have a relationship between the Dr. Molina's question, Professor Otsuka's comments, and Dr. Kai's question. That is depend on the situation, I think.
No. I'm talking about the Glisson first or transaction first. I'm talking about. My question is.
I see.
You know. So in your presentation, you said you reject the Spiegel-Glisson first. After that, you start the transaction. So for me, it's little bit difficult to recognize the Spiegel-Glisson, tiny Glisson.
Okay.
So usually for us, after we will start transaction first, and after that, reject the Glisson, Spiegel-Glisson.
Okay. Thank you very much, Professor Kaiser. May I reply, Dr. Ishii? Okay.
Yes, please.
Okay. Thank you very much. And we usually apply the Glissonian pedicle resection in the total Spiegel resection with attraction of the hepatocellular ligament right side and the left lateral section up. We can usually recognize the Spiegel branch, you know, on the backside of the hepatocellular ligament, and it always we can recognize in the left hemihepatectomy, preserving the Spiegel pedicle. So we usually try first the Glissonian pedicle in recognizing the branches.
Okay, next we will try the pedicle first, Glisson pedicle first. Okay.
Yeah. Thank you.
So maybe you're doing the connecting tissue between the HD ligament and the Spiegel.
Yes.
That
just like Rene capsule dissection.
Thank you very much.
I see. Thank you.
So we should go ahead to the next speaker. Thank you very much, Dr. Ishii and Professor Otsuka.
Thank you very much. See you again.
So next speaker is Dr. Go Shinke from Kansai Rosai Hospital. That is also the famous hospital in Japan. They are doing a huge number of lap liver resection, hepatectomy, and this time he's going to present kind of multi-center study. Is that right?
I'm sorry.
That changed.
I changed the topic. Yeah.
Oh, thank you very much. So please go ahead and let's start.
Thank you. Thank you for introducing. I start sharing the slide. Can you see the slide?
Yes, yes.
Okay, I start. Firstly, sorry to change the title. Today, I talk about surgical outcomes with laparoscopic liver resection for hepatocellular carcinoma in short term, just in our institution. Laparoscopic liver resection has been reported as a safe, minimally invasive and effective approach to the treatment of HCC. We evaluated operation outcome from May 2010 through June 2021 in our hospital. In our institution, we recently experienced around 70 laparoscopic liver resection in a year. Between May 2010 and June 2021, 393 patients underwent laparoscopic liver resection for HCC at Kansai Rosai Hospital. We compared 393 patients who underwent LLR for HCC and 128 patients who underwent open liver resection for HCC between 2004 and June 2021. You can see the patient characteristics in the LLR group and OLR group. In LLR group, mean age was older, and cases in open liver resection stage was more progressed. The operation time for laparoscopic liver resection was significantly longer, but the amount of bleeding was significantly smaller. After we investigated in the subgroup divided with procedure, the tendency was same. The mortality and the morbidity, which is hemorrhage, biliary fistula, was smaller in LLR group. About postoperative laboratory data, which is total bilirubin, white blood cell, CRP, was lower in LLR group. We think that means LLR was smaller invasive for the whole body on the surgery. LLR was undergone in the safety compared to OLR. The operation time for LLR was significantly longer, but the amount of bleeding was significantly smaller. The postoperative hospitalization days of LLR was shorter, but it is not significant. LLR was equivalent to OLR with respect to short-term outcome. Next, we divided cases into 3 groups. By the period the surgery was underwent, there was no difference in the patient characteristics by the period. In later period, we often placed sheet tube, which avoids the postoperative bile leakage. The operative time in late period in HR0 and S was longer. The blood loss was significantly smaller in later period. The postoperative hospitalization days was significantly shorter in later period. The rate of postoperative biliary fistula was reduced progressively in later period, which may be related with a hospital stay. In the later period, the amount of bleeding was significantly smaller comparing in the early period, and the postoperative hospitalization days was significantly shorter. Especially the rate of postoperative biliary fistula was reduced progressively in later period, which was 0% in the later period, even though it was 6% in early period. LLR was performed more safely in later period. About discussion, comparing the outcome of LLR with OLR, there was some selection bias between 2 groups. There are some reports about the surgical outcome of multiple institutions in Japan. Comparing our result with that data, we investigated about the safety of LLR performed in our institution. And next, in the early period, the rate of biliary fistula was significantly higher than in the median or the later period. We investigated the features of cases with biliary fistula by the analysis of LLR in the early period. Firstly, the patient characteristics in our institution and multiple institution, which is 31 institutions, was not different. Cases in multiple institutions underwent between 2000 and 2010s. The outcome of LRR in our institution was equivalent to the outcome of multiple institutions. As for the operation time, the blood loss, and the hospital stay, but the rate of mortality and morbidity in our institution were actually higher than the outcome of multiple institutions. As for the higher rate of the mortality and morbidity in our institution, maybe the result in the early period have been mostly relative in our hospital, which we mentioned another table. This is about patient characteristics with biliary fistula in the early period. There was no difference without biliary fistula. In cases with biliary fistula in early period, only the amount of bleeding was significantly larger, so that the patient with biliary fistula stayed longer in the hospital. About analysis, the biliary fistula, in case, About analysis about the biliary fistula in case with biliary fistula in early period, the amount of bleeding was significantly. Recently, we often place the sheet tube in which was suspected to occur the biliary fistula. Accordingly, the rate of that was significantly increased, actually 0%. This is our conclusion. LRR was undergoing safety compared to OLR. The safety of LRR was more progressed with accumulation of cases. Thank you for listening. This is my presentation.
Thank you very much. Thank you, Dr. Shinke. So first, I would like to reconfirm about your data. The operation time in late phase, late era, is longer than early era. Is that correct?
Yes, yes.
So,
yeah.
What make that kind of difference between the kind of diseases or styles, or what do you think about that?
Maybe the reason is we are considering about that same, and maybe the reason is firstly operator is some member was changed, and maybe one of the reasons is that younger operator procedure the resection, and maybe a second reason is resection of the liver parenchyma. We usually use Q-cell recently, but in the early period, we usually use crush clamp method. So it's maybe faster than the, using Q-cell. That is the reason of that.
I see. Thank you very much. So now this paper is open for discussion, and we have already got a question from Professor Kaiser. He asked, you can talk by yourself? Oh, he asked one question. He said, could you teach me the indication of sheet tube? His question.
Yes, thank you for question. Actually, there is no fine reasons. Just in operation, sometimes we can see the bile leakage in the surface on the liver. We have to repair the bile duct, and in that time we usually use the sheet tube, but there's no another how can I say, some no reason, just in operation impression of by our experience.
So you don't use the sheet tube for kind of just precaution, just that kind of bile leakage at the end of this operation is there in just in case you use sheet tube, and other than that you don't use that kind of sheet tube.
Sometimes okay, sometimes we can see not actually by leakage, but on the surface on the bile duct, we can see some slice on
stain,
that kind of that time we sometimes use sheet tube.
I see. So at the time of the end of the operation, you see the surface of the transaction and see some kind of yellow bile-ish spot is there. In that case, you put the sheet tube.
Yes.
I see. Other question is there? Is there any other questions? So in the hourly error, you got a little bit large number of bile leakage after operation. In that case, the bile leak did come from peripheral part of the biliary tree or central part.
I see. I'm sorry about we don't have now that data, so we investigate about that later.
So I'm asking that because during the dissection of Grisonian pedicle, you got something, or at the point of liver parenchyma transaction, that kind of a question I have, so I asked you.
Okay. Maybe later we investigate about that, and in the article we put on that.
That can relate it to that kind of a transaction procedure you mentioned before, and that can be changed with that kind of procedure changing, maybe, but I'm not sure about that. But I'm a little bit curious about that.
Okay, thank you.
Is there any other question? Professor Kaisu, is it okay for you?
Yeah, it's okay for me. Thank you.
Thank you very much.
Thank you.
So thank you very much, Dr. Shinke. So please go ahead and have a good paper. Thank you very much.
Thank you so much.
So let's go to the next speaker. Charles is here. Is he here? Professor Lin is here? No. Hello, Mary. Is Professor Lin here?
Professor Lin didn't enter the meeting room, so we can start.
He's not yet.
Yeah.
Okay. Actually, Professor Lin is from Taiwan. He is vice dean of famous ILCA Taiwan, but he's not here yet. So we are going to move to next speaker, Dr. Mikiko Kidachi. She is from Kitasato University, same university Professor Kaiser, and she's going to present about ruptured HCC cases. So please go ahead and start it, please.
Hello, thank you for this opportunity to present. I'm going to talking about our study entitled 9 cases of laparoscopic hepatectomies for ruptured hepatocellular carcinoma. One life-threatening complication of hepatocellular carcinoma is spontaneous rupture of the tumor, leading to intraperitoneal hemorrhage and shock. The incidence of spontaneous HCC rupture has been reported as 3 to 26% and is associated with a high rate of in-hospital death. Ruptured HCC patients have a higher incidence of peritoneal dissemination after hepatic resection than those with a non-ruptured HCC. However, actually, there are some reports that ruptured HCC didn't increase the risk of dissemination after hepatic resection than those with non-ruptured HCC. The prognostic influence is still controversial, and the best treatment approach for ruptured HCC is still debated. Hemodynamically stable patients with no active bleeding should be managed conservatively, followed by a definitive treatment like liver resection or TACE. Patients who have hemodynamically unstable with signs of active bleeding should be managed to achieve immediate hemostasis. TAE is the least invasive approach to stop bleeding. The objectives of our study were to demonstrate that laparoscopic hepatectomy is a valid treatment in case of ruptured HCC. This is a retrospective study, and 9 patients underwent liver resection for ruptured HCC between February 2012 and November 2019 at our institution. As a side note, 491 patients with HCC patients underwent laparoscopic hepatectomy during this period. There were 6 male and 3 females with a median age of 64 years. The most common initial symptom was abdominal pain. 2 patients developed hypovolemic shock upon admission. Of the 9 patients, 3 patients had cirrhosis. TAE was performed in 6 patients, and this led to staged hepatic resection. 2 patients achieved spontaneous hemostasis, and the remaining 1 patient was discovered his rupture of HCC during surgery. The median largest size was about 12 centimeters. Many studies have reported that the size more than 5 centimeters are associated with high risk of rupture. However, size is not an absolute criterion for rupture, as HCC as well as small as 3 centimeters have been found to have ruptured in this study. The duration from diagnosis of the rupture to surgery was 36 days. Let's have a look at the results we had. A total of 5 patients underwent pure laparoscopic hepatectomy, as shown in this table. Hand-assisted laparoscopic surgery was performed for 3 patients, and 1 patient required conversion to open surgery, and 4 of them were anatomical liver resection. Median operating time and volume of blood loss was 428 minutes and 508 milliliter. And I will show you a comparison with non-ruptured HCC patients later. Peritoneal dissemination was detected in only 1 patient. Patient 8 was performed spigal lobectomy. She was diagnosed unexpectedly rupture on MRI. TAE was carried out and celiac angiogram revealed feeder vessel arising from S1 branch from middle hepatic artery. 1 month after embolization, CT showed viable area of the tumor and an additional TACE was performed. Celiac angiogram revealed that the tumor supplied by the right gastric artery associated with previous TAE. TACE wasn't completed because of the risk of embolizing non-target organs. So she had a variety of feeder vessel of the tumor. And she had also cirrhosis, which is one of the risk factors of postoperative bleeding. The postoperative course was good, and she was discharged 8 days after surgery. However, she presented to our emergency department with cardiac arrest and died from intra-abdominal hemorrhage 16 days after surgery. Autopsy report states that the cause of intra-abdominal hemorrhage was bleeding from the resection surface of the liver. We had 8 patients without any complications, but this was the only case with postoperative complications, and unfortunately, it was clavien dingo grade 5. This table shows the preoperative and postoperative outcomes in 15 non-ruptured HCC patients with tumors larger than 8 centimeters from August 2014 to December 2021. A total of 11 patients underwent pure laparoscopic hepatectomy, and hand-assisted laparoscopic surgery was performed for 3 patients, and 1 patient required conversion to open surgery. Perioperative and postoperative outcome between non-ruptured and ruptured group showed no significant differences in terms of operating time, blood loss, and hospital stay. We had 2 patients with complication with grade 2, and peritoneal dissemination was detected in only 1 patient. To determine the 3-year survival rate, we selected patients who had been followed up for over 3 years. Results of the study show that there seemed to be significant differences. So ruptured ACC patients maybe have worse prognosis than non-ruptured ruptured patients. In summary, we experienced 9 cases of hepatectomies for ruptured ACC, and 5 patients were performed with a pure laparoscopic hepatectomy. The survival rate at 1 year and 5 years were 56% and 22%. Surgical factors such as median operating time, median volume blood loss, and median postoperative hospital stay was similar across between ruptured HCC group and non-ruptured HCC group. 3-year survival rate in ruptured HCC were 33%, which seemed to be significantly worse than those of the non-ruptured HCC group. I will conclude by saying that laparoscopic hepatectomy may be acceptable procedure in ruptured ACC, but its indication should be carefully considered. Thank you for your kind attention.
Thank you very much. Thank you for a kind of a detailed presentation for ruptured HCC cases for lap liver resection. So now this paper is open for discussion. Is there any comments or questions? I want just confirm about the background of the patients. There is 5 non-viral hepatitis patient is there among 9 patients. Is that correct?
Yes, that's correct.
So that 5 patient is not have the chronic liver disease, or other than hepatitis, viral hepatitis, they have some kind of NASH or alcoholic or other kind of liver cirrhosis or chronic.
Yes, most of them have alcoholic
I see.
liver disorder or NASH.
I see. I see. And they have fibrosis or not?
We have, yeah, let me show you.
Yeah.
This is the clinical characteristics and cirrhosis for 3 patients.
Yeah. So maybe this group is kind of a little bit better liver function than usual HCC patients. Is that correct? Or in a university condition, this is not so unusual, but this kind of comparable to other patients.
Thank you. I didn't mean for it to be secret, but I have a patient clinical characteristic with is about non-ruptured ACC patients. This is a comparison between the characteristics. The liver function.
Yeah.
About the liver function, there is no significant difference between the non-ruptured ACC and ruptured ACC.
I see. I see. I understand well.
But I think about the cirrhosis, maybe 33%.
Yeah, maybe
ruptured ACC. So
yeah.
I'm not sure, but
there may be some difference, but
yeah,
you're not sure about
I'm
that.
not sure because we have only 9 patients.
Yeah, that's right. And 3 patients did some kind of a surgery first treatment without embolization.
Yes, because 2 of them had a spontaneous hemostasis, and 1 of them found the rupture during the surgery. So 2 of them had a spontaneous hematosis.
I see.
Yeah.
So there's no emergency operation cases.
Yes, absolutely. We have no emergency operation cases.
Embolization for 6 patients, and 2 patients is got spontaneous hemostasis, and some kind of scheduled operation was done after that, and 1 patient is rupture during operation.
Yes.
I see. I understand well. So how do you feel about the strategy of this kind of ruptured HCC? We usually first try to do embolization, and after that scheduled surgery we are doing, but in use of laparoscopic procedure, you can some kind of modify this kind of strategy or not. Laparoscopic is important. Oh. There's any comments about that?
I agree with your strategy for ruptured ACC, but we experienced operating death case.
Yeah.
So actually she had strong adhesions because of previous TAE.
Yeah.
So if the patient expected that strong adhesion due to hemorrhage or necrosis. Maybe it is one of the difficulty in adhesiolysis.
Yeah.
And maybe this is one of the cause of the postoperative hemorrhage. So we have to consider about the laparoscopic hepatectomy for them very carefully.
I see. In that specific case, there is 2 or 3 times embolization, you said?
Yes, she took 2 times of the embolization.
I see. Yeah. That may be important, 2 times. You mean that 2-time rupture?
But second one is not performed because there was a branch from the right gastric artery.
Yeah.
So
First
we
time,
couldn't perform the test because
Yeah.
The risk of embolizing non-target
yes, I understand.
organs.
So in that time, you just directly moved to surgery after that angiography?
Yes.
I see. I
Absolutely.
see. So first embolization, and second time you're trying to do the embolization, but got
We
the
canceled
favor
it
about the
and plan to
collateral
surgery.
abuse and that.
Yeah.
I see. In that situation, that may be very difficult situation for operation, and but still, she or he survived. Actually, out of hospital, she got some kind of emergency. She once.
Yes. She
Yeah.
discharged at once,
Yeah.
and
But-
16 days after surgery, she died.
Yeah. Very difficult situation, I think. So first, you treat well, and she discharged, but came back.
Yes.
Why that kind of things happen? Collateral vessels from around the unexpected area. There's some kind of artery from unexpected area, and that can make some kind of late bleeding or something, because
Autopsy reports also states that there was adhesions between resection surface and posterior wall of the stomach.
I see.
It means near the hepatic artery.
I see.
So, and there were at that point, at that area, we saw the strong adhesions.
I see.
So this is the one of the risk factor, I think.
I see. Maybe possible take-home message is you should do surgery after earlier timing of embolization. Is that correct? With before getting severe adhesion.
Pardon me.
So I think from your talk, I think we should do earlier stage after embolization. We should do operation because before getting severe adhesion, we should do operation. That is correct. That is
that is correct. Because a recent study showed that the duration from TAE to stage hepatectomy was 40 days. This result was obtained because rate rupture after TAE for initial rupture occurred mainly within 1 month. So we recommend to do the hepatectomy within the 40 days after TAE.
Yeah. Thank you very much. That very important report. So please refine and get some kind of good paper. Thank you very
much.
Thank you. So we are going to move to the next speaker. Next speaker is Dr. Victor Molina. Dr. Molina is here. Oh, thank you very much.
Yes, I'm here.
You are here from at the first, and please present your good paper and for us give a chance of a discussion. Please get started.
Okay, I don't know if you have the slides, or I
Yes.
can share my, yes?
Yeah, I can share the slides, and when you make the presentation, you can remind me to go to the next one. Okay.
Okay, start.
Oh, so not yet prepared for. Oh, good.
I will try to do it this way. Firstly, good morning from Spain, and thank you for your kind invitation. I prepare a review of the current paper of the laparoscopic resection in hepatocellular carcinoma with his benefits. Next one. First of all, I started with the current indications in Europe for liver resection. As you see, in the recommendations are only for solitary tumors without vascular invasions and preserved liver function, childhood A, without clinical significant portal hypertension. With these strictly indications, we can achieve a low morbidity, less than 30%, and low mortality of less than 3% in the first 90 days after the surgery. Next one. In this slide, you can see the current guidelines of the European Association for Liver Disease, published in 2018. And next. Click next, please. Next, okay, that one. No, after. And the problem, no, the previous one. And with this, you can see that only in the two first stages is recommended liver resection for solitary tumors. The problem is that with these indications, less than 10% of the patients at the moment of diagnosis, as you know, can benefit from this approach. These guidelines are based on the BCLC algorithm for the treatment of hepatocellular carcinoma, but is also based on a lot of studies they have published in the past year. Next slide. One of the first and most important studies published was this article published in 1996 by Dr. Bruch, the first one in which they wanted to see the prognostic value of the preoperative portal pressure measurement. Next one. In this paper, they saw that if they measure if they had a gradient between the systemic venous pressure and the portal pressure greater than 10 millimeters of mercury, the patients had worse postoperative results with more descompensation and more mortality. Next. These publications was also followed with a lot of publications confirming that results that we can summarize in one article. Next slide, please. That this is the article, meta-analysis published in 2015 in Hepatology, where they published 5 years overall survival of less than 30% in those patients with clinical significant portal hypertension. These bad results have made that the recommendation is not to resect those patients. But all these works were based on open liver resection. Next slide. In the next years, the laparoscopic approach was extended over the world, and we could see good results with this approach in cirrhotic patients. That made that a lot of surgeons asked if they could expand the indications in these patients. Next. Next one. One important work was published in 2015 by Dr. Maurice and colleagues, an important meta-analysis with more than 2,000 patients, where they compare the open liver surgery and the laparoscopic liver resection in patients with hepatocellular carcinoma and cirrhosis. Next one. In this study, they found that the laparoscopic group had better results with less postoperative ascites and less postoperative liver failure. Next slide. And also they saw no difference in the positive surgical margins, 5 years overall survival, and 5 years disease-free survival. Next slide. With these good results, the authors conclude that the laparoscopic approach had better postoperative results with less liver test compensation and the same oncological long-term surgical outcomes. Well, these were good results that made us if we can expand the surgical indication for these patients. Next slide. Well, the next logical step for us was to think, well, if the patient that could benefit from this approach could be those patients with clinically significant portal hypertension of those patients with child B cirrhosis. Next. Next one. Well, for that reason, we published in 2018 a study in hospital clinic where we made a retrospective study studying 15 patients submitted to laparoscopic liver surgery. They were very selected patients with minor portal hypertension with a maximum of 14 millimeters of mercury as maximum and peripheral lesions. We took those patients and compared them with 30 patients without portal hypertension, but the same characteristic of liver tumors and analysis in the preoperative settings. Next slide. In those patients, we saw that we had a good 5-year survival with equal results of the patients without portal hypertension. Next slide. And with a good hospital stay and without major liver complications. Only one patient had ascites that needed a treatment with diuretics. Next slide. These good results were also confirmed by other groups in 2020. In 220, Dr. Azulay presented a study of 79 patients, all of them with clinical significant portal hypertension. Some of them, 27, submitted to laparoscopic liver surgery, the others to open liver surgery. And they saw that only the patients submitted to laparoscopic liver surgery achieved good textbook outcomes as they define it, without major liver complications and without mortality at 19 days of surgery. They also confirmed that the laparoscopic approach in this type of patients can reach good results. Next slide. Moreover, other authors studied the results also in patients with child B. In this multi-center study of more than 17 centers published last year, the authors compare 200 patients submitted to laparoscopic liver surgery with patients with open liver surgery, all of them child part B patients, and they found that the laparoscopic group had a good 5-year survival of 65% with a good 5 years disease-free survival of 37%. They didn't reach significant difference within the open group, but it was clearly better survival. The authors conclude in this study that patients with child B, especially those with score 7 or 8 without portal hypertension, had good results. All these preliminary data and study have changed also. Next slide. have also made that in the recent publication of the BCLC in this same year in hepatology, they paid special attention to these patients, and they clearly say that in selected patients with child B or clinically significant portal hypertension can be resected. To conclude my review, next slide. I will say that with the current data and evidence, the laparoscopic approach is the approach of choice in patients with hepatocellular carcinoma and fibrosis. The initial experience and preliminary data published suggest that we can expand the indication for liver surgery to those patients with clinically significant portal hypertension and child B. But to know more which patients could benefit from this approach, we need more evidence and more studies. Next one. Thank you for your attention, and I will be glad to answer your questions.
Thank you very much. Thank you for your kind of detailed and also clear presentation review for this kind of severe cirrhotic patient lap liver resection. This paper is now open for discussion. Is there any comments or question? Oh, Professor Lin is here, but he's not. In Japan, also maybe in East Asia, we are not usually measuring the portal vein pressure. So instead of that, we are using the platelet counts and esophageal varices. Using that kind of condition, we are making the indication of liver resection for that cirrhotic patient. How do you feel about that kind of indication? You think we also should do or do better do measuring of portal vein pressure for each patient? How do you feel about that?
Well, I think that also it's an invasive measurement. Is very precise to define those patients that could benefit. We know that those patients with more than 20% of millimeters of mercury can have variceal bleeding. So I think that it's a tool that can help to extend the indications because you more precisely say what patient is going to be bad results in the postoperative setting.
I see. Sometimes with the low platelet patient, we did first splenectomy and waiting a few months, and after that getting a high platelet count, higher platelet count. In that case, in that timing, we do a lap liver resection. That kind of a strategy sometimes we use, but in that condition, portal hypertension is changing or not? Do you think?
I think that is not changing because what is showing the portal pressure is that the liver has fibrosis and a difficulty to have flow between the portal and the systemic venous system. So the problem is not that there are low platelets. The problem is on the liver.
I see. I see. The severe fibrotic liver is the most important factor.
Yes.
How about the collateral vessels? That is also important, or?
Yes, we saw that some patients don't have a very high portal pressure because they have a lot of circular of venous with collaterals.
No.
So, but in this patient, the gradient is not so useful because that patient also has a very big fibrosis and the results are not going to be so good. So in this case, if you have a very big chunk or a lot of collaterals, the gradient is not so precise.
I see. So that depends on the condition of collateral vessels,
Yes.
and other things. Yeah, that's interesting. Yeah, because we are not doing the measuring the portal vein pressure, so that we are very interested about the presentation and that kind of topic of study in our field. Thank you very much.
Thank you very much.
Thank you very much. Thank you for your very nice presentation. So Professor Lin is here. So maybe Charles here? Oh.
Yeah, hi, hello. Hi.
How are you?
Good. Long time no see. Yeah.
I see. So looks you're good, and I'm happy to see you here. And we are moving into the sixth presentation, and now we are going back to your presentation, and you are going to present today case followed by microwave ablation therapy for HCC. Is that correct?
Yeah, thank you. Let me start to share my slides.
Actually, Charles Chan Wei Lin is the professor, actually vice dean of famous ILCAT Taiwan right now, and he's a very good liver surgeon in Taiwan, and he's going to present, but today is not liver resection, but other kind of minimally invasive liver treatment. Thank you very much. Please go ahead.
Thank you, Professor. Can you see my share screen?
Yes.
Okay. Thank you for the invitation. And although this is a small topic, and nothing about the laparoscope surgery for liver tumors, but we have some successful experience. So I would like to share this modality with you. And in the first, I'm a surgeon, of course, for liver tumors, for HCC and the liver mets. Resection is still the gold standard. But sometimes, I would say sometimes ablation is not bad. And for tumors, especially located in this area, very close to the junction of vena cava and the hepatic veins, resection is really difficult. So you can see, come back to Iwate criteria, if you want to resect a tumor located in segment 4A or 5, 8, and sometimes 7, then you can see, according to the score, segment 4A is 4, segment 8 is 5, and then proximal to major vessels, there will be 1. And if you want to do sectionectomy, there will be 3. So totally there will be in advanced or expert stage. That means the tumor, the resection is difficult. So we have a patient like this several years ago, 64 years, HCC in segment 7. So you can see tumor over here. And at that time, another surgeon to radiofrequency ablation for the tumor. But several years later, 2 years later, the tumor recurrence over here, surrounding the ablation scar. So of course, that is very difficult to treat. And at that time, the only thing we can do is hepatectomy. So you can see we decide to go laparoscope. And because of a previous treatment, there are a lot of adhesions around the liver. So we spend a lot of time to do the enterolysis and try to identify all the vital structures. So you can see that the liver is a little bit cirrhotic. And because of the adhesion, everything become more difficult. So the first thing, we identify the hepatoduodenal ligament and try to prepare the Pringle. And this is the way we do Pringle routinely, preparing for the inflow control. Then I start to extraglyconian approach to dissect right pedicle. And again, because of previous treatment, some adhesions, so dissection of the vital structures becomes more challenging. So gradually I can identify this is right hepatic artery. And then because before I go any further, I apply the inflow control using the Foley catheter, try to decrease the bleeding when I do further dissection. Then gradually I can identify, I'm not sure this is right or right anterior. So I apply Bulldog. Then we can see demarcation between right and left. So I start to do the parenchymal dissection and opening the caudate lobe. They will widening the window of right pedicle. And I guess that this is V5, the first important structure. And then dissecting carry on. Then right now I'm doing with the right hepatic ducts. Then control using Hemolog. And after that is a V8. You can see I open a hole on the V8, but because thanks to the pneumoperitoneum, there is not much bleeding. I can still dissecting further and control the proximal side of the V8. Then this is right broadband. Then this is the most important step over here because I know tumor recurrence around here. And because of a previous ablation, so dissection around here become the anatomy is not very clear. So I'm not sure what is this. So all I can do is gradually, gently dissection around the structure over here. Then gradually I realized that is the roots of right hepatic vein. And because of a previous ablation, the vein become a little bit thicker than normal structures. So gradually I can dissect between hepatic vein and right hepatic vein and the vena cava. And then dissection control the right hepatic vein here. And you can see the tumor actually sits behind right hepatic vein. So after I transect the right hepatic vein using endoGIA, then the tumor is over here. So I dissected the tumor along and from the roots of the hepatic vein and the vena cava. So finally, I can do laparoscopic right hepatectomy, although quite challenging, but safe. So this is several years ago, we performed redo right hepatectomy after ablation, the recurrence. So I can do this, but that is very challenging. So for this one, we have another patient, 55 years old, B carrier, a lobulated tumor around segment 4A and 8 here. So this time, of course, we can still do right hepatectomy, but the surgery will be challenging, and the patient need to sacrifice a lot of liver. So you can see tumor over here, very close to the roots of hepatic veins. And the alpha fetoprotein is very high, so definitely there will be HCC. And this is another patient, small tumor, only 2.3 centimeter, but located very close to the vena cava and the root of the hepatic vein. Again, we can do resection, but that will be challenging. So what will you do? We can do resection just like the first case. And some surgeons say the tumor is very small, but in a difficult area. So we can do ablation. But based on the first case, the tumor is very close to hepatic veins. The local recurrence and the incomplete ablation rate after ablation is very high. And some surgeons say tumor adjacent to major vessel, so surgery is risky. So suggest TACE, but we know TACE is not definite treatment. And some surgeons say it's multiple HCC, very high risk of recurrence. So just use medical treatment, including target therapy, immunotherapy, and cell therapy. So this is why we propose multimodality approach for advanced HCC. And we use TACE followed by ablation. And we use laparoscope assist ablation because of the tumor location close to the diaphragm and the roots of hepatic veins. Percutaneous approach is difficult. And some patient we use TACE followed by surgery. And for medical treatment, we need, because of the health insurance guideline, we have to do selective TACE for 3 times, then apply for target therapy. So again, for tumors located in this area, the treatment is very challenging. So we know for ablation, tumor ablation size equals to surgical margins. Even we do ablation, we still need margins. But for tumors in this area, that is not easy. And for tumors in difficult location, percutaneous approach is also difficult. So we choose to do laparoscope approach. So come back to our case, tumor located in this area. We do TACE first, and 4 days later, we do laparoscope assist the microwave ablation. So you can see tumor over here. And 1 month later, we follow MRI. You can see the alpha fetoprotein drop to 5.5. And the MRI showed good ablation without any suspicious enhancement. And also the alpha fetoprotein, you can see after the treatment dropped to normal, within normal limits, and keep low in almost 1.5 years follow-up. So a few months later, we have second patient, only 42 years old, also suspicious HCC surrounding the roots of hepatic vein over here. So this time again, the tumor is over here. Resection is not easy. So we decide to do this multimodality treatment. So you can see 3D reconstruction tumor over the roots of hepatic vein and the vena cava. And last year, May, we do TACE first, and 5 days later, we do laparoscope microwave ablation. So this time again, we are very happy that the ablation is very successful. The alpha fetoprotein level dropped to normal and keeping low. And there is no recurrence in the follow-up. And this is the 3rd case. You can see tumor over here again, very close to the vena cava and the middle left hepatic vein. So this time, again, we do TACE followed by microwave ablation, and successfully treat the alpha fetoprotein drop to 5.6 and keeping low level, and the patient shows no recurrence. So this is what we say it's a multimodality treatment for HCC surrounding hepatic vein and the vena cava. And because of course we can do TACE, but TACE is not definite treatment. Recurrence rate is very high. And we can do laparoscope assist microwave ablation, but because of the tumor close to hepatic veins, so we are a little bit worried about the recurrence only to ablation. So we combine these 2 modality. Then we follow up MRI 1 month later. Then if the ablation, if the treatment is not complete, so we will add further treatment if needed. And luckily, in all these 3 cases, we follow the patient after TACE and the ablation, and there is no recurrence. So I would like to share this experience with you. Okay.
Okay.
Thank you. I think it's the finish of my talk, and I will happy to take questions.
Thank you very much. Thank you, Charles. So very beautiful presentation for your history of treatment adjacent to the HVs and IVC, HCC, and you are now so prefer to this kind of TACE followed by ablation, that kind of things. So I have a question. How about your indication for this kind of treatment? Tumor size, tumor morphology, and other things. Do you have make some limitation for this indication, or you can do everything you can do, put on this kind of strategy?
Yeah, thank you. It's a very important question. The first thing I would like to say, ablation is only for smaller tumors, usually smaller than 4, or maximum 5. Of course, some papers prove we can use 2 or 3 needles to ablate maybe larger tumors, but as a surgeon, I don't trust. So for me, I only use this modality for tumors, for smaller tumors. The largest will be 4 centimeter, and I will do resection for all the possible possibilities, but I only use this combined TACE and ablation for tumors located in this area, because resection is quite difficult. If you do open, that would not be easier. If you do laparoscope or robots, that is still challenging. And sometimes the tumor is only 2 centimeter, 2 or something, and you have to resect the whole right lobe. So sometimes we think we can do more minimally invasive. So we try to do this. So answer your question, I will use this combined modality only for tumors located in this quite critical area, and only for smaller tumors.
I see. Thank you very much. I understand well. And how about the kind of single tumor with a thick capsule, HCC, at that area? You can get the partial resection with that on the margin of the capsule in that kind of a tumor?
Yes, sometimes we do only tumor resection.
Yeah.
But again, for these 3 cases, the tumor is very close to the vena cava and the roots of the hepatic vein. So I'm worried about that. Maybe you can do this operation, but I'm afraid.
Oh yeah, I'm afraid also.
Yeah.
But so you are now choosing this kind of strategy for that kind of tumor also.
Yeah, only for this area.
I see. And also, I have one question. Before some maybe radiologists said after TACE, ablation area get bigger, larger area, we can get the ablation after TACE. Yeah. You are saying the same things?
Yeah, we have another small series. We do TACE followed by ablation using single needle radio frequency ablation, 12 minutes, we can achieve 5 centimeter.
I see.
So this is why we combine these 2 modalities.
I see. So maybe TACE is for that kind of effect, or you are expecting the combination effect for those?
The TACE is, of course, that is a long history of treatment for HCC. And the second thing is we use it for devascularity and increase the area of ablation.
I see. I understand. Thank you very much. So how about there's another question or comment for Professor Lin's presentation? Are you okay doing this kind of strategy? It's good strategy, and maybe you can get a long-term outcome after this kind of treatment. And
yeah, I will do. The first one is follow almost 2 years and no recurrence. I'm very surprised, actually.
Thank you very much. It's good. So can we move to the last speaker? Mary, is there Professor Suses?
Yeah, Professor Suses is just leaving the meeting room, so we need to follow the next procedure.
So there's no more other presentation? He's leaving?
Yes.
Oh, so maybe we should do first for him? How are you?
We can just leave to the next step. Is about the journal's introduction by the editorial office.
I see. So unfortunately, Dr. Tusus is not here. He was here, but he's leaving. And so unfortunately, we can't get his presentation, maybe next time. So please go ahead about the journal introduction.
Yes.
Thank you, Mary.
Okay. Yeah. Thank you so much. I'd like to share the screen first.
Thank you very much.
Okay, first, I'd like to thank all of the experts participating in today's webinar, and thank you so much, Professor Morris, to organize a special issue and such an excellent webinar today. And I'd like to say we editorial office and Professor Morris to organize such special issue, current and future treatment of hepatocellular carcinoma. We aim to collect the research from the leading experts around the world and discuss the current difficulties and future perspectives, explore different minimally invasive treatment techniques to improve prognosis and make evidence-based treatment decisions. So today, we are so honored to here to invite all of you to participate in the webinar, and we look forward to the excellent papers from you. And the next important point I like to say is that our journal, Minimally Invasive Surgery, is focusing on the field of HPV surgery, and that is also the field we will pay attention to in the following years. And our journal also sets the journal awards, and today I like to stress the Minimally Invasive Surgery 2023 Best Paper Award. This award is to encourage the high quality contributions to academic research. And for this award, 3 articles will be selected for this for it, and 1 first prize and 2 second prize after a thorough evaluation by the scientific committee of minimally invasive surgery and led by editor-in-chief. And the winners will be announced in February 2024. And for the papers published in minimally invasive surgery from January 1st, 2021 to December 31st, 2022, we will have the will be elected to have the chance to win the award, and both regular and special issue submissions will be considered. And the selection criteria is as follows. We will evaluate from the overall value to scientific research, originality in the research objectives, novelty in the opinions or in the research approaches, significance to the research field and interest to readers, scientific soundness and data quality, and number of citations in 2023. The data will be from Google Scholar. So we at our office hope that all of you can take part in the special issue, and look forward to your excellent contribution. And our editorial office will provide the full service of article processing and standard peer review in the process. And if you have any questions, you can contact us at any time. And when the article is published online, we have the social media platform to share the latest research in it, and to expand the exposure of all the researches to attract the experts' attention. And that's it for the short introduction. And if you have any questions, you can contact us at any time through such contact information. And again, thank you so much, the chairs, speakers, and audience of the webinar, Current and Future Treatment of Hepatocellular Carcinoma. And thank you so much for your support. Professor Morris, I finished the short introduction of the journal. Thank you so much.
Thank you very much. So we are going to close this webinar for special issue. So thank you all for your participation and a good presentation and discussion. Thank you very much. So maybe please be safe and healthy, and maybe also get good results for your studies. And we will see you all in person very soon, I hope. So we are going to close this webinar. Thank you, everyone. Thank you very much.
Thank you, Professor Morris. I just have one request. Can we open the camera and we can have
take a photo or something?
Yes.
So can you?
Okay, finished. Thank you so much.
Yeah, thank you very much. So see you soon around, and be safe and healthy. Yeah, thank you very much.
Thank you. Bye-bye.
Bye-bye. Thank you.